dialing in this afternoon, and thank you to PACOM for sponsoring this event. My name is Rob Anthony. I'm with the Office of eHealth Standards and Services, which is the office that coordinates the EHR Incentive Programs here at the Centers for Medicare and Medicaid Services. I am going to talk a little bit today about Stage 1 meaningful use and do something of a deep dive into some of the details about meaningful use. I did want to mention that in addition to the conferences, the webinars that we do with PACOM, we will also be presenting at the upcoming PACOM conference in October, so I hope you'll all stop by to see us then and get some of your questions answered there. I will be doing some Q&A at the end, so if you have questions, please feel free to put things on the in the Q&A box on the side, and I'll try and go through as many of those as I can when we get to it. We are getting a little bit of background noise from folks, so if you can make sure that you have your line muted, that would be best. And in the meantime, I'm going to go through. Sorry, I'm clicking through. There are video recordings of this webinar and future webinar series for the EHR Incentive Programs that are on the PACOM website. You can see how to get to them here at the bottom, the pacom.com education tab, and then there is a tab for the CMS webinar series that you can click through and see this and past webinars. And as you can see, this is for the upcoming Clearwater Beach, the PACOM conference in October. So I want to talk about what we mean when we talk about meaningful use. Meaningful use is sort of the cornerstone of the EHR incentive programs. And you hear the term meaningful use knocked around quite a bit with folks. But not everybody immediately understands what we mean by meaningful use. It's become sort of a catchphrase without people really understanding it. But there is a specific meaning behind meaningful use. It was specified by the high-tech portion of the Recovery Act, in which Congress specifically mentioned incentive payments for the meaningful use of EHR technology, the use of technology in ways that would meaningfully affect patient care. And rather than leaving that very up in the air, they actually specified three specific components of meaningful use. One is, as I said, that use of this EHR in a manner that's going to meaningfully affect patient care. The example that was given was e-prescribing. The use of certified EHR technology for electronic exchange of health information between providers to improve the care coordination. And then finally, the use of certified EHR technology to calculate and submit clinical quality measures that would be used as the basis for improving care. And as you're going to see as we go through and look at some of these objectives, those components that were expressed within the HITECH Act really made their way into the objectives that are required as being a meaningful user in order to receive an incentive payment. But the entire goal was really the idea of using your certified EHR to improve the quality of care, safety of patient care, and to reduce well, health disparities, but also to reduce some of the costs that are associated with things like duplicative tests and so forth. There is an effort to engage patients and families in their own health care. So you'll see some objectives that emphasize giving information to patients in an electronic format or providing clinical summaries after an office visit. The idea here is to engage patients in their own health care so that they are fully apprised of what they need to do. We talked about exchanging information across different between providers to improve care coordination, but there is also the exchange of information with public health agencies to improve population and public health. So you'll see some objectives within there that require you to report immunization data to an immunization registry or syndromic surveillance data to a public health database. And accomplishing all of these goals while placing an emphasis on privacy and security. It's always important to us to make sure that the privacy and security of patient information is properly addressed. So we ask as one of the core objectives that all providers, whether they're eligible professionals or hospitals, have to meet is to do a security risk analysis and to have a plan in place to correct any deficiencies in their system. So that's really what meaningful use, the driving force behind meaningful use. It's really those goals that were used to folks, we are getting a little bit of feedback here, so please make sure your lines are on mute. So again, these were the goals that we used to really inform the objectives that were developed for the core and menu set for providers. And this is what meaningful use is in the end. And the whole idea behind meaningful use is that meaningful use is what has to be achieved in order to receive the incentive payments. That's actually mandated by Congress, is that you have to achieve meaningful use in order to receive incentive payments. So we often get people asking, to get a broad overview of what meaningful use really is. I do like to use this mnemonic with folks. It doesn't encapsulate everything about meaningful use, but it does a pretty good job of giving you what the basic structure is. So if you got one formula that you can remember here, this would be at 15 plus 5 plus 6 equals meaningful use. And down below you'll see how that is represented. There are 15 core objectives that every eligible professional has to achieve. There are 5 objectives that they must select out of a menu set of 10 that they have to report on. And then there are 6 clinical quality measures that you would have to report on, 3 that come from a core or alternate core set, and 3 that are selected from a menu set of possible 38. So 15 core objectives, 5 menu set objectives, and 6 clinical quality measures. Once you've achieved those or reported on those, that is what meaningful use is. The thing that I do like to let people know is that the core objectives and the menu set objectives are objectives that you have thresholds that you have to achieve. So some of these have a percentage that you have to exceed. E-prescribing, you have to e-prescribe more than 40% of the prescriptions that you write during the reporting period. Some of them are yes-no thresholds. So implementing drug, and drug-allergy interaction alerts. You have to attest that you have implemented those for the entire EHR reporting period. So core objectives and menu objectives have thresholds that must be met or exceeded in order to meet meaningful use. Clinical quality measures do not have thresholds. They are simply things that you report on. So they have numerators and denominators like the core and menu set measures may, but the clinical quality measures don't have a threshold, a 10% or a 20% you have to achieve. You just have to report on those. So in stage 1 of meaningful use, that's where everybody begins their meaningful use process at stage 1. Some of you may be a little bit more familiar with the meaningful use program, and you may have realized that we have a rule out now or a proposed rule out for stage 2. We published that back in March. There was a public comment period. And that closed on May 7th, and we are looking at the end of this month or the beginning of September to release a final rule for stage 2. But stage 2 represents the next step of meaningful use. Stage 1 is where everybody begins meaningful use. So these are the requirements that, regardless of the year that you come in, that everybody is going to have to meet at first. In stage 1, there's going to be a reporting period of 90 days for your first year of participation and then a year subsequently. So what that essentially means is that you are going to demonstrate meaningful use. You're going to achieve those thresholds for those different objectives over a period of any 90 consecutive days during the calendar year for eligible professionals. After that, then your EHR reporting period is going to be an entire year. So if you started in 2012, you would do 90 consecutive days. It could be January 1st through March 31st. It could be July 1st through the next 90 days. Any 90 days within that calendar year will suffice. After that, in your second year of meaningful use, you're actually going to have an entire calendar year. So from January 1st to December 31st, and then you would attest after that. The reporting on this is through attestation, so you're going to report that you have achieved these objectives for meaningful use to CMS or to your state Medicaid agency in order to demonstrate that you have achieved meaningful use and to receive a payment. You're going to do that reporting to us through a process called attestation, and that really is just logging on to our website or logging on to your state Medicaid's website and answering a series of questions, providing some numerator-denominator information to show that you have been a meaningful user for the reporting period. As we said, there are objectives and clinical quality measures that are part of meaningful use. The objectives are the core and menu objectives with thresholds that you have to meet. The clinical quality measures are simply measures that you report on. The reporting, it can be either a yes-no or a numerator-denominator attestation. That again is some of these objectives have percentage thresholds that you have to achieve, like e-prescribing with the more than 40% of your prescriptions have to be electronically transmitted. Some of them are yes-no. When you go into a test, and I'm going to show you some of what attestation looks like, when you go into actually attest to these things, you're going to get some questions. So on implementing drug-drug and drug-allergy interaction checks, it will ask you whether you implemented those alerts for the entire reporting period, and you would actually attest yes or no. So there'll be a yes-no reporting on that. For e-prescribing, there will actually be a denominator, which is the number of prescriptions that you wrote during a reporting period. There will be a numerator, which is the number of those prescriptions that were electronically transmitted. And then CMS or the state Medicaid agency will actually do the calculation of the percentage. So when you attest, that's how the reporting will happen. We often get the question about how many patients' records have to be maintained within certified EHR technology. Some of these objectives do have measures that account for all the patients that you see during the reporting period, and some of them have a measure threshold of 80%. These are many of the recording objectives, so recording vital signs, recording demographic information, have a requirement that for more than 80% of all patients seen during the EHR reporting period have to have their records in the certified EHR technology. So that's basically what your threshold will be. You have to have a minimum of 80% of your patients in EHRs, but keep in mind that that is 80% of patients that you see during the reporting period. So it is 80% of patients that you see during that 90-day period in stage 1. In your first year, or 80% of all the patients in your second year for the entire year. It's not that you have to go back and digitize past records. It's not that every single patient has to be captured. We do recognize that in stage 1, a lot of practices will be making a transition from paper to electronic, and that's why we have set this 80% threshold. So these are the core objectives for eligible professionals, and I'm going to concentrate here on eligible professionals because I know that most of you being office managers are working in a practice setting, and you'll be working with eligible professionals, either physicians primarily on the Medicare side, maybe nurse practitioners on the Medicaid side. There are separate objectives for eligible hospitals. A lot of them overlap with what you'll see in the EP core objectives or menu objectives, but there are some differences. And if you want to take a look at those, you can take a look at our website, which is www.cms.gov/EHR Incentive Programs, and that will give you some information about the eligible hospital objectives. But here are the EP core objectives. These are the 15 core objectives that all EPs either have to meet or have to qualify for an exclusion for, and I'll talk about exclusions in a second. But here are things that we talked about, such as e-prescribing. This is all about ensuring, patient safety and bettering patient care. Computerized provider order entry of medications, medication orders. We talked about some of those goals about engaging patients and families in their own health care. So you see objectives like providing patients with an electronic copy of their health information, providing clinical summaries for patients for each office visit. A lot of these core objectives focus on data collection, and stage one really is about collecting data on patients and getting it into a structured format into your EHR. So you see things like recording demographic information, maintaining problem list and med list and medication allergy lists on patients, recording vital signs or smoking status for patients. There are other objectives that focus on the exchange, the electronic exchange of information between providers across different settings of care, so improving care coordination. So you see things like exchanging key clinical information among providers of care. And then as you'll see in the next slide, there are some that focus on the improvement of population and public health and focus on exchanging with public health agencies. But I do want to draw attention to number 15. Number 15 is a core objective. It is a core objective for both EPs and for eligible hospitals. It is an objective that nobody has an exclusion to. Everybody has to do this, and it is all about the privacy and security of patient records, taking a look at your system, doing a security risk analysis, and coming up with an action plan to take care when there are any type of risks that are presented by your system. This is the menu objective for eligible professionals. You have to choose 5 out of these 10 menu objectives. At least one of those 5 has to be what we call a public health objective. That's number 9 and number 10 down here. And this again goes to the discussion that we had earlier about the goal of improving population and public health. So this is submitting immunization data to immunization registry or syndromic surveillance data to a public health agency. But there are other menu objectives that focus on the transmission of information between providers, so a summary of care record that is sent to the next provider of care after each transition of care or referral, again providing patients with access to their health information, and then other objectives that really focus on patient care and safety, like drug formulary checks, generating lists of patients by specific clinical conditions, sending reminders to patients about follow-up care or preventive care, medication reconciliation when there has been a transition of care. All of these objectives point to those goals of meaningful use that we discussed earlier. Obviously, there are a lot of different objectives here, and I can't go through every single objective, but we have done that for you. And you can see information about each and every objective by going to our Meaningful Use Specification Sheets on our website, and there's the address there, the CMS.gov EHR Incentive Programs website. If you go to the Meaningful Use Overview tab and scroll to the bottom, you can download spec sheets for eligible professionals or for eligible hospitals. Those spec sheets, there is one spec sheet for each individual core objective and each individual menu objective. It will give you what the objective is. It will give you what the measure of that objective is. So in other words, the threshold that you have to achieve. It'll tell you what the exclusion is for that objective, if there is one available. It'll define specific terms that may be unique to that objective. So for example, one of the things that eligible professionals have to do is for more than 50% of patients provide a clinical summary after an office visit. We often get the question, well, what do you mean by an office visit? What constitutes an office visit? On those spec sheets, we actually define that term of what an office visit is. We show what the attestation requirements will be for each objective, so what exactly the denominator is going to be that you'll fill in, what exactly the numerator is going to be. There are a number of bullet point important points of information or hints about or tips for meeting those particular objectives. And then finally, there are links to FAQs that have to do with the particular meaningful use objective or to do with the standards or the standards that may be employed in storing that information or in transmitting information. We have FAQs that are available that you can link to get to more guidance. So a lot of people use these meaningful use specification sheets when they're implementing. A lot of people refer to them as sort of a Bible or a blueprint for them for implementing. So I encourage everybody to take advantage of those and download them. So we've talked a couple of times about exclusions for meaningful use objectives. We often get the question from people, well, what if an objective is not something that I normally do? What if it is not something that is a regular part of my clinical practice? Do I still have to meet that objective in order to become a meaningful user? Well, we do recognize that not all of these meaningful use objectives are applicable to everybody's clinical practice. And so for most of these objectives, we've provided what we call exclusions. Essentially, if you meet the requirement of that exclusion, you would not have to report on that particular objective. You would be exempted from it, you would be excluded from reporting on it, and it would not affect whether you get a meaningful use payment. So if you exclude from it, you can still receive your incentive payment, and everything counts for you. So we quote a couple examples here at the bottom, but chiropractors don't typically prescribe. So it's going to be hard for them to meet the e-prescribing requirement. Well, for the objective for e-prescribing, there is an exclusion that if you write fewer than 100 prescriptions during the EHR reporting period, either 100 prescriptions during that 90-day reporting period in your first year of meaningful use, or 100 prescriptions in that full calendar year in your second year of meaningful use, then you can be excluded from meeting the e-prescribing objective. Dentists don't typically perform immunizations as part of clinical practice. So for the menu objective for reporting immunization data to an immunization registry, one of the exclusions is that any provider who does not routinely perform immunizations as part of their clinical practice can be excluded from that. The important thing to keep in mind is that you have to meet the requirement of that exclusion. So for our e-prescribing example, if you wrote 101 prescriptions during the reporting period, then you have to meet the e-prescribing objective. You have to meet that measure of more than 40% being e-prescribed. So if you were not able to meet those particular requirements, you have to meet the measure of the objective in order to be a meaningful user. I wanted to reiterate clinical quality measures after we talk about our core objectives and our menu objectives. There are clinical quality measures. As we said, there are no thresholds that you have to meet for those clinical quality measures. You're just reporting on those clinical quality measures. And it's made really simple by the way that certified EHR works. You're actually going to always report the clinical quality measure values directly out of your certified EHR. So your certified EHR generates a report. You will literally transcribe the numerator and denominator and exclusion information from clinical quality measures directly into the attestation module for either CMS or your state in order to report your clinical quality measures. Again, not a threshold that you have to meet, you just report on them. There is a core set of clinical quality measures for eligible professionals. If any of those core clinical quality measures, which focus on things like smoking cessation and blood pressure and obesity, if any of those three core don't fit with your clinical practice, in other words, a 0 comes up in the denominator of those because you don't have any patients to whom those apply, there is a set of alternate core that you would choose replacements from. You would simply choose replacements that make sense for your clinical practice. In addition, after reporting on either those 3 core or 3 alternate core, you're going to choose 3 from an additional list of 38. You're going to choose 3 that are relevant to your clinical practice. So there are some pretty broad clinical quality measures available in that list. A primary care practice, for example, might choose from a list. There is a clinical quality measure on monitoring hemoglobin A1C levels. An endocrinologist obviously would choose something like that. It might not make sense for a different type of specialty, and they might choose something else entirely. Not every specialty is represented under those clinical quality measures. So we do know that there are certain areas like pathology and radiology which have a hard time finding a clinical quality measure that specifically applies to them. That's okay. Reporting zeros is acceptable in clinical quality measures, and you can simply select if none of the clinical quality measures are applicable to your scope of practice, you can actually just select a random 3 from that list, and you'll end up reporting zeros on them. Again, because there aren't any thresholds to meet for CQMs, that's acceptable to do. So I want to talk about some of the things that you want to think about as you implement. I realize that some of you are already on your way to meaningful use, but we do some regular surveys of people who are participating in the program to see what some of the primary barriers are for them to reaching meaningful use. We also mention up here AIU, which is adopting, implementing, or upgrading under Medicaid. You have that option in the first year to receive a payment for that. And as we have gone through and talked to different providers, these are the areas that keep popping up again and again and again. And we always like to review these because we think that it can help inform those areas where you want to make sure that you're taking a look as you go to implement. These slices of the pie are not necessarily representational. If we were to make a representational pie chart, this particular area on knowledge gaps would be by far the largest piece of this pie. And it represents the gamut of things. We have providers that are really in a situation where they don't know anything at all about the program. They want to know who's eligible to participate, what is the program all about. Some of you as office managers may be in that very position, because we talk to a lot of office managers who essentially get delegated the task of selecting an EHR or implementing that EHR in the practice by physicians who own the practice. If you are in a position where you need that type of very basic knowledge, or if you're in a position where you are implementing and you need really detailed knowledge about specific meaningful use objectives, we do want to direct you to our site, the EHR Incentive Programs website that we gave earlier, the www.cms.gov/EHR Incentive Programs. Not only is it the official website for the Medicare and Medicaid EHR Incentive Programs, but you're going to find a lot of resources available on that website. And I'll cover some of them later, but just so you know, in addition to the Meaningful Use Specification Sheets, we do have some introductory guides that give you a good overview of both the Medicare and Medicaid programs. We really wrote these with office managers in mind, because we know a lot of you sometimes get delegated is a nice word, stuck with sometimes the task of implementing these. So please do visit our website. One of the things that pops up occasionally also was state onboarding. It tended to come up more often in the beginning of the program when fewer states were actually actively participating or had an active program where they were paying. As we've had more states come on board, we now have 45 states that are actively participating in the program and are making payments, and we do expect the remaining states to onboard by the end of 2012. We have fewer people who are experiencing that barrier because of a state Medicaid agency hasn't got their program up and running. But there are still a couple of areas where we're waiting for states to get on board. But two that I really want to call attention to, especially for those of you who are at the very beginning of this process, is, well, firstly, technical support. This was a theme that comes up again and again. It comes up across every type of provider or every type of participant that we talk to, whether it is an office manager who is implementing or a physician who has been in practice. Everybody has this issue of not knowing what they want to know about certified EHR. So either not knowing what is a certified EHR, not knowing which EHRs are specifically certified for this program, not understanding what the certification process is, or they have basic questions about product selection. What do they look for in an EHR? We often get the question of, what EHR should I buy for my X practice, my cardiology practice, my oncology practice? What's the best EHR for my practice? And then as people get into meaningful use and get further down the road on implementation, the questions come about how to use their EHR most effectively, how to use the tools within their EHR to meet those objectives of meaningful use. We like to draw attention to that because these are good questions to have in mind as you move forward with the process. A lot of people don't think about them until a little bit later into the process, and sometimes people don't think about them until after they've already selected a product. But it's certainly something to be thinking about as you move forward, and certainly a conversation to have with your vendor And we do note that one of the barriers that people cite fairly frequently is, for lack of a better term, vendor support, and not necessarily that the vendor doesn't support them, but they're looking for knowledge from their vendor that they may not necessarily be able to get, or that they may not realize that they have to pay extra for. So one thing to keep in mind as you move forward and to think about as you're talking to different EHR vendors is what kind of support do they provide, and what kind of support do they provide not only for technical issues, so actually getting your EHR implemented, getting it plugged in, making sure that all the lights turn on in the morning, but also what kind of support might they offer specifically for meaningful use? What kind of support do they specifically offer for the EHR incentive programs? Many people turn to their vendors and ask them questions about meaningful use and about how they're supposed to calculate the different objectives. And sometimes the vendor doesn't have that type of knowledge available. Sometimes they don't have those type of resources. Sometimes the vendor charges extra for those type of resources. All of those are good questions to ask before you commit to a particular electronic health record. The other question that people should probably ask about is how long it takes to actually get the software implemented. We've had some various reports of anywhere from 6 to 18 months for time to actually onboard and get your software, your EHR, implemented in your practice, because so many people are taking advantage of meaningful use and are participating in the EHR incentive programs. It means that there are a lot of people who are approaching vendors and trying to get their EHRs in place. So be sure to ask about what type of time frame it is for you to actually implement. We release a lot of FAQs on our website. It is another great area of guidance for meaningful use. We use our FAQs in a variety of ways. We use them to answer pretty basic questions. So there are some questions on who is eligible for the Medicare programs, who is eligible for Medicaid. How soon do I get paid? The answer is 6 to 8 weeks, by the way. But we also go to very advanced questions. So there may be very detailed questions on what version of HL7 can be used in transmitting electronic data to an immunization registry. If you don't know what that means, that's okay. You'll learn more about it as you get a little further in, but those are the type of detailed questions that we can get into, and they help clarify for people exactly how they meet the objectives. So we always like to tell people that the FAQs are a great resource, and that a great way to learn about new FAQs is to sign up to our listserv. You can sign up on our website. That is the website above, the cms.gov EHR Incentive Programs website. There's a tab on the left for the listserv. It is free to sign up for the listserv, and we use the listserv to announce not only when a new FAQ comes out, but we use it to also announce when there are new educational resources like our introduction guides or our tip sheets. We use it to announce new webinars that we're doing. So, for example, there was a listserv that went out about this particular webinar for PAYCOM, but other webinars we also do. When we do national provider calls, when there are deadlines that are approaching for the program, all of those are things that we announce on our listserv. So it's a great way to stay in touch about the EHR incentive programs and how to meet meaningful use in general. But I want to go over some of the most frequent questions we get, because this will delve a little deeper into what people are looking at when they're looking at meaningful use. And then I'm going to go over some more recent questions that we can talk about as well. So one of the questions that we get is, how should an EP who orders medications infrequently calculate CPOE? CPOE is computerized provider order entry, and it is one of the core objectives for eligible professionals. The requirement for CPOE is for the numerator consists of all patients who have a medication order in the EHR that was ordered using CPOE. It is not necessarily limited to the EP. It can include patients who are within the practice who have had medications ordered by another EP. There is a an exclusion for CPOE that allows an EP who orders fewer than 100 medications during the reporting period to exclude from that objective. But we quickly discovered that there are a number of EPs who order or prescribe more than 100 medications during that reporting period, but they don't order frequently enough to actually meet the percentage threshold that is required for CPOE. So if you're an eligible professional, or if you are an office manager who has EPs within your practice that prescribe more than 100 medications during the reporting period, and they maintain a medication list that includes medications they didn't order, that is typically what happens in a practice where you are sharing an EHR between multiple physicians, but that EP orders medications for less than 30% of the patients with a medication in their medication list. If all three of those things apply, then the EP can limit the denominator of the CPOE to patients for whom the eligible professional has previously ordered medications. Essentially, this makes it a little easier for EPs to meet that CPOE requirement, but not be penalized because they order less frequently than other eligible professionals. We often get the question of what it means to be seen by the EP. If you have familiarity with some of the objectives in stage 1, you'll notice that a lot of the denominators are patients seen by the EP during the EHR reporting period. Well, what do we mean seen by the EP? This comes up often because there are some specialties that don't necessarily see patients in the traditional sense. However, you need to have seen patients in order to qualify for meaningful use, because you cannot have a denominator of 0 in those objectives. So we released this FAQ in which we clarified that obviously patients seen by an EP would include all cases where there's a physical encounter between an EP, an eligible professional, and a patient. And it would also include telemedicine encounters. Those are actually seen by the EP. But in those specialties where there's an EP who does not have those type of face-to-face or telemedicine encounters, you can essentially establish a definition that works under that. So as long as that definition is consistent across the reporting period, you can use that as seen by the EP. And the example that we use in this FAQ is there are some cardiologists, for example, that don't actually see patients face-to-face or have telemedicine encounters. What they do is they provide consultative advice to different physicians, to referring physicians on EKGs. So they actually don't see the patient, they see the patient's information, they see the patient's EKG. However, they establish that as actually seeing a patient, that consulting on the EKG is seeing the patient, and they establish that as their denominator, and then they get information through exchanging with other physicians, and in that way they're able to have a denominator of patients seen by the EP during the reporting period. If I see patients in a setting without an EHR, can I enter their information into my EHR once I get back to my practice? So I may work in a location that is not equipped with certified EHR technology, but back at my practice, I actually have an EHR that I use. We often get this question from people who work in skilled nursing facilities, which may not have that available to them. And the answer really is that yes, you could do that, because for the vast majority of objectives, we don't specify a time frame of when information has to be entered into the EHR. So for example, sometimes demographic information on a patient may not get into an EHR until well after the actual office visit. Vital signs might be recorded well after the actual office visit takes place. That's okay. We just specify that during the reporting period for those patients seen during that reporting period, information is recorded, except for one objective, and that objective is computerized provider order entry. And we specify that computerized provider order entry has to happen before an action can be taken to fill the medication order. That's the point of computerized provider order entry, is for a person to enter that medication order and then for any alerts or contraindications to pop up and to have that provider be able to take actions to prevent that medication from being fulfilled and harming the patient. Because you can't enter that CPOE after the fact, it may be difficult for folks to actually enter the CPOE information and qualify by entering it in a different location. However, if you can work it in such a way that the medication order is not fulfilled before you enter that into the EHR, then in fact you could do that. We get a lot of questions about exchanging key clinical information. One of the objectives is to test the exchange of key clinical information between providers, and people often ask what we mean by electronic exchange of that key clinical information. So can they use electronic physical media such as a CD-ROM, a USB? We've even had people ask that can they use a printout, since after all it is something that is transmitted from their computer to a digital printer. But in fact, when we say key clinical information exchange, electronic exchange, we really do mean electronic exchange. So none of those actually work. You can't use physical media such as a CD-ROM or a USB. You can't use a printout. It has to be electronic transmission of that information. So what methods can you use, which is our next most popular question. And we actually have been very broad about this. We really have limited it to using your EHR to produce a particular file format, what we call a continuity of care document or a continuity of care record. So you've got to use your EHR to generate that, and then you can use any other means of electronic transmission to send that CCD or CCR to the next provider of care. So it could be email, it could be an FTP site, it could be an information exchange, it could be any of a variety of ways that are actual electronic transmission of information. We often get questions about whether the exchange of electronic information can happen within a practice. This is especially in a multi-specialty practice where you may be a primary care professional on the first floor, but there may be a gastroenterologist on the fifth floor, and you are moving that patient along to the gastroenterologist. Can you exchange that information with somebody who is in your practice and shares the same EHR? And the answer to that is that no, we did specify in the regulation that to actually count as exchange, you have to exchange with a different legal entity. So if you are in a practice with somebody, you're all the same business entity, you're not a different legal entity. And you've got to exchange with somebody who is not on the same EHR as you. They have to have a distinct certified EHR. That's not a different EHR. It doesn't mean that they have to be on a completely different type of EHR. So for example, we could both be on Epic, but we have to be on different instances of Epic. We can't be sharing a server. We can't be sharing the same license. It's got to be a different certified or a distinct certified EHR. There are a lot of questions about capturing clinical data for CQMs. A lot of people have noted that not all of the EHRs out there are accurately calculating clinical quality measures. A number of them are not necessarily pulling clinical quality measure data from the same areas that providers are entering that information. So it led to a lot of people wondering about whether they have to ensure that all of the clinical data is captured and whether all of the clinical data has to be captured in exactly the right field that the EHR uses to calculate that clinical quality measure. And at this point in time with stage one, the answer is that, no, that doesn't have to happen. We do encourage providers to capture as complete clinical data as possible on patients, but at this point in time, we're not requiring that all of that clinical data has to be captured in the EHR or that it has to be captured in exactly the right fields. Stage one is really about putting the EHR into practice and getting familiar with capturing some of that data. As we move to stage 2, we'll be looking a lot more at EHRs and how clinical quality data is actually calculated and captured, and we'll learn more about that when those final rules come out. But the requirement that you do have to meet is this one here at the bottom, and we talked about this before. CQM data, to meet the CQM reporting requirement, you just have to report that data exactly as it's generated from your certified EHR. So that printout, that report that comes from your EHR is actually, you're transcribing that information literally numerator to numerator, denominator to denominator in the attestation module in order to report on CQMs. We often get the question about who is allowed to enter information into an EHR. A lot of physicians are under the impression that they have to enter all of that information. That isn't true. In general, we don't specify who can enter information at all. For a lot of these things, like recording demographic information, we know that some practices actually interface with a practice management system to get some of that information. People use front office staff. They may, I know of some practices that use billing staff to enter some information. There can be medical assistants who put that information in afterwards. There's a variety of ways for that information to get in the system, and it does not have to be entered by the eligible professional themselves. But we do specify for one particular objective, and this is the CPOE or computerized provider order entry objective, how that information gets entered. And we specify that CPOE has to be done by a licensed healthcare professional, and that's somebody who is licensed according to state, local, and professional guidelines. A licensed healthcare professional, not necessarily the EP, his or herself, but just somebody who's a licensed healthcare professional. Because it's got to be somebody who can exercise clinical judgment in case of an alert. And then as we discussed before, that has to happen before, when the order first becomes part of the record and before any action can be taken to fulfill the medication order. So when you think about these three requirements for CPOE, you have to think again about the intent. The entire point of CPOE is to enter a medication order in, and then an alert pops up, and if an alert pops up, somebody can look at that alert and say, yes, that applies to this particular patient, and they could stop that particular medication order from being fulfilled. So in order for all of those things to happen, it's got to be a licensed healthcare professional who can exercise clinical judgment and who enters that order into the EHR before an action can be taken to fulfill it. So even though we talked about exclusions earlier, I like to highlight we still get this as one of the second most asked questions at CMS. If you don't regularly perform an objective as part of your practice, can you be excluded from meeting it? The answer is that yes, you can if you meet the requirements of that exclusion. The exclusions are available only where we say they are available. So if there is not an exclusion provided for a measure, for an objective, it is something that you have to meet. So for example, we talked earlier, everybody has to meet the privacy and security, doing a security risk analysis every year. Everybody has to meet that. There isn't an exclusion. If there is an exclusion and you meet the circumstances of that exclusion, that's fine. You can claim the exclusion. It won't count against you. E-prescribing, if you write fewer than 100 prescriptions during the reporting period, you'll be excluded from having to report on it. If you're not able to meet the objective and there's no exclusion available, then you're not able to meet meaningful use and you won't receive an incentive payment. Meaningful use is an all or nothing proposition, so it isn't possible to get a portion of your incentive payment. You either have to meet all of the objectives or qualify for exclusions for some of them. And then finally, the top question we get asked is, can people use drug-drug and drug-allergy interaction alerts to meet the clinical decision support measure? There are two objectives. One is to implement drug-drug and drug-allergy interaction alerts for the reporting period. Another is to implement one clinical decision support rule during the reporting period. Both of those are core objectives that you have to meet, and we often get asked if you can use one to meet the other because, after all, drug-drug and drug-allergy interaction alerts really are clinical decision support. But they are separate objectives, and they do have to be met separately. So the answer to that one, unfortunately, is no. You have to do a clinical decision support alert in addition to these drug-drug and drug-allergy interaction alerts. We do have some new FAQs available on our website. I won't go into all of these, but these are the numbers. You can look them up on our website. There are people, if you want to change your attestation information after you've attested or you've received an incentive payment, maybe you realize that you made a mistake when you entered something. Maybe you do what I do very often and you might have fat-fingered something, hit a couple of keys at the same time. You realize your mistake later. There is a process to do that. It essentially begins with you calling our EHR Incentive call center and or EHR Information Center rather, and they'll get you started on the process. Some people have noted for the Incorporate Clinical Lab Test Results measure that the report from their EHR is actually giving them a numerator that is larger than their denominator. However, you can't enter a numerator larger than your denominator during the attestation process in our attestation module. The reason you may get a numerator larger than your denominator, as many people have probably figured out, is that sometimes you order a test and it may return 15 results. If you order a Chem 7, you're going to get, I believe it's 14 results as a process of ordering that test. However, your EHR may only tag one order, and it may not necessarily tag that order to the results. So you might get a numerator larger than your denominator. The short answer to that question is actually that you will actually make your numerator equal to your denominator and just keep the information in case you have an audit. You have to explain that to folks. Similar to the question that we get about can you exchange information between EPs who share an EHR, we get the question of can you provide a summary of care record to the next EP if that EP is also somebody who shares your certified EHR and include that in meeting meaningful use? And the answer to that is no, it works the same way. You have to actually provide a summary of care record to somebody who is not sharing that EHR. Because they share the EHR, they already have access to that information, and you don't need to actually give them a summary of care record. There are questions about EPs who work in multiple locations, whether they can, whether they have to perform a test of data exchange, whether it's the exchange of key clinical information or sending submission to data, whether they have to do it once or whether they have to do it for each location. There's also a question if you have a lot of EPs in your practice, do you have to perform those tests for each and every EP? The answer is that we provided in the regulation that you can do a single test for each physical location, and that will serve for every EP within that physical location, but it does have to be a test for each physical location, regardless of how your certified EHR is set up. Even if your EHRs from multiple office locations refer back to a single server, you have to initiate a test from each of the physical locations in order to demonstrate that it can be done from each location. But you don't have to do it for each and every EP in the location. Sometimes people ask us whether they can test the exchange of key clinical information or test the transmission of data to a public health agency from a test environment or a test domain of their EHR. If you don't know what that means, that's fine, but for those of you who do have a test domain or a test environment, it's essentially not populated with actual patient information, and that's why people want to test from that environment, because they're not ready to actually exchange actual patient information yet. And yes, you can exchange from, or you can test that transfer from a test environment. However, you should be aware that there are some public health agencies that will not accept from they won't accept dummy data, they won't accept test data, and in that case, you have to abide by whatever the rules are of the public health agency. We did issue an FAQ, actually a revision to an FAQ, that for patients who see, or EPs who see patients in multiple practice locations that have different EHRs, that when you go to calculate numerators and denominators for attestation, obviously you have to have information from all of those practices, all of those different EHRs. We used to have guidance that basically said that you would have to get down to the actual unique patients across all of those locations, but as anybody who knows a little basic math, you can't add numerator to numerator and denominator to denominator and actually end up with a greater ratio and percentage. So we are allowing people to simply add numerator to numerator, denominator to denominator without have to actually do that culling of unique patients. It makes it a little easier when you go to a test. Probably not as important for most of the folks on this call, but we did recently release an FAQ about capital leases for critical access hospitals, and previously we had said that a capital lease doesn't count for reasonable cost for critical access hospitals, but now we are allowing that. I would encourage people who are interested to take a look at the FAQ specifically about that. It'll explain the reasoning. But probably more important for some of you, especially those of you who may have providers who work not only in your office but actually work within a hospital environment as well. There are questions. Previously, we did not allow EPs to use hospital certified EHR technology for meaningful use. The reasoning was that hospitals have different objectives that they have to achieve. And EPs can't meet meaningful use with just hospital technology. However, we did alter our systems to allow what we call the hybrid use of both ambulatory and inpatient EHRs on the part of EPs. It is possible to use different components of a hospital certified EHR in order to meet meaningful use. But please keep in mind that you couldn't solely use that hospital EHR because, as I mentioned before, it's not complete for an EP's needs. You wouldn't be able to meet all of the objectives for an EP. For example, hospitals do not have an e-prescribing objective. So hospital inpatient certified EHR technology doesn't have an e-prescribing module, and EPs need to be able to meet e-prescribing in order to meet meaningful use. Also, the inpatient EHR won't have any of the EP clinical quality measures that you have to report on. So you'd have to have access to ambulatory technology in order to achieve meaningful use. And then finally, I just want to draw attention to, we get a lot of questions about audits. Some of you may have read in various places that the audit process has begun. That is true. We have started to do a first early wave of audits. There's an FAQ that on our website that lets people know that Figliosi is the auditing contractor, and they've reached out to a handful of hospitals and EPs to talk to them. So we do get a lot of questions about what exactly we're going to be looking for on an audit. Obviously, that's the purpose of an audit, so we are not going to give people a complete game plan of everything that we're going to look at, but I think that we can talk a little bit about some of the basic principles of audits. We are looking at sort of catching the obvious on audits, and I like to always give the example of, there are denominators that are common across a number of these objectives. That's the number of patients that are seen during the EHR reporting period. If those denominators among different objectives vary wildly for you, that's something that we're obviously looking at. It raises a little bit of a red flag for us. We are focusing on substantial non-compliance, so we're less concerned about a number that may be 3 or 4 patients off in its count versus a number that might be 3,000 or 4,000 patients off on a count. Keep in mind that this is a government oversight program, so we are concerned about fraud and abuse, but we're also concerned about how we spend taxpayer money in order to fight fraud and abuse. So we're looking for that balance between the cost of oversight and what we would recover on an incentive payment. And in doing so, we're trying to employ a balance between a high-tech and a hands-on approach. So in that sense, a lot of audits are actually going to be desk audits. So you may get an email from somebody who says, hey, can you send us a copy of your clinical quality measures report? Versus actually a hands-on approach where somebody actually shows up and does a field audit. And then finally, where it's possible, we're certainly going to be maximizing existing data sources. This may be especially true on the Medicaid side, where states will have to verify patient volume. Obviously, they're going to be looking at their own data bank or database of claims to see if that the patient volume jives with what they have there. So what can you do as far as audits? The first thing, and I know it seems obvious to folks, but the thing that I always tell people is to please check and double check your information before you enter it. The number of people who've come back and wanted to change things because they've made a simple error in math, or they've made a simple error in input is surprising. But it definitely happens. So you have an opportunity when you go through and do your attestation to actually check before you hit the submit button. Please do that and make sure that it jives with everything that you have. And then finally, retain all of your relevant supporting documentation. We recommend 6 years. That's what we have in the regulation for post-attestation. Any electronic or paper documentation that you use to calculate your meaningful use measures, anything that you used for your clinical quality measures, the printout from your system on clinical quality measures. I also generally recommend that people actually print out information from their EHR, their reports that they used for attesting. A lot of people don't realize that their EHRs aren't necessarily time-stamped. Some EHRs, some are, some aren't. But if your EHR doesn't timestamp, then it may not be able to provide you a picture of that 90-day period years from now. That 90-day period may change because of information that you enter later. So make sure that you have a printout so that you can show the numbers that you used. There are a number of resources available. We talked about the incentive programs website. We do have these introductory guides, these very basic guides, our frequently asked questions that have everything from basic to very advanced guidance. We do have the listserv that I talked about, which we use for major program announcements and helpful resource announcements. There's a meaningful use attestation calculator on our website. It's sort of like a TurboTax. You can go in, you don't have to sign in and give any identifying information, but you can put your numerator and denominator information in, and you can actually test whether you would meet meaningful use before you actually go through attestation and submit that. And then there are user guides, PDF guides that give screenshots for both the registration and attestation process. It'll walk you through that entire process and give you all of the information that you need to register and attest. These are great guides to help you through that process, so please do go and download those PDFs to help walk you through. If you have questions about certified technology, you can go to the Office of the National Coordinator's website. They maintain what we affectionately call the CHAPL, the Certified Health IT product list, and that's a list of all the products that you can use to meet meaningful use under this program. And then finally, Paycom, as I said earlier, has their on their site, the paycom.com site, under the Education tab, there is a CMS webinar series tab, and that archives all of these webinars that we've done with them and will continue to do with them, and you can go back to those to take a look at what we may have said about Stage 1 and what we'll say about Stage 2 upcoming. Here's the website to direct link to that. This is a look at what those user guides look like that I mentioned previously. This is an attestation user guide. It's going to show you a screenshot of what you should do, and it'll tell you exactly what steps you need to take and what to do next. And it'll give you tips on information that you should have handy as you go through the attestation process. Well, normally at this point I have a little slide that says question and answer. I obviously don't have that on this one, but I'm going to go through and take a look at these Q&As that we have on the right. And I'm going to, as I'm doing both the queuing and the A-ing, bear with me because I'm going to be sort of reading through all of this myself and won't be able to filter ahead of times. So I'm going to go and somebody asked if an exclusion applies for a particular measure. Should the numerator and denominator be entered in addition to indicating the exemption? That's a great question, and actually you won't get a chance to enter that numerator and denominator. The exclusion for that particular measure comes up first, and it will tell you what the exclusion is. So let's take our e-prescribing exclusion. The exclusion will say, you know, if you are an EP that prescribed fewer than 100 prescriptions during the EHR reporting period, you would qualify for an exclusion, and then it will ask you, does that exclusion apply to you, yes or no? And you would fill in yes because it applies to you, and then it would just take you to the next objective. You wouldn't even get a chance to enter the numerator and denominator. Somebody asked, for the additional 3 CQMs, can you report a numerator or denominator of 0 and still have met the reporting requirement? And you can. CQMs can report zeros and meet the reporting requirement for that. If a physician attests and doesn't meet meaningful use, can he or she reattest again later? Obviously, I'm assuming we're talking about the 90-day reporting period here. So if you have 90 days and you go through and you enter your information, you discover that you don't meet meaningful use, you can go in, reattest, and you could choose a different 90-day reporting period during the calendar year. And if you met meaningful use, then you would qualify for an incentive payment, so you can do that. If a physician meets meaningful use for January, February, March, can they attest for those 3 months later in the year? And yes, the answer is that you can basically attest anytime during the calendar year for your 90 days, anytime after those 90 days during the calendar year, or for 2 months following the end of the calendar year. So you would essentially have until if you did your 90 days in 2012, you would have until the end of February 2013 to submit your attestation. Let's see, sorry, I'm scrolling through here. A lot of people obviously heard the sounds that I heard. What exactly is CMS requesting, and where is it to be placed in the EHR maintain problem list? So the problem list actually, how best to describe this? I probably can't answer specifically for your podiatry practice, and I can't answer specifically for your EHR. That's something that you're going to have to consult with your vendor about, where you actually enter it. But the problem list is actually a list of all of the current and active diagnosis or any past or relevant diagnosis for a patient, and the problem list consists of a field or multiple fields that store that data in a structured format. So essentially every provider has to maintain a problem list of those current or active diagnosis, or an indication that there isn't an active problem for a patient, as structured data within that field or multiple fields for a problem list. If you'll take a look at that meaningful use specification sheet that I mentioned earlier, it'll give you a little bit more detail about specifically a problem list and the type of things that can be recorded. It will also give you some information about the structured format that we use for that data. We essentially use an ICD-10, or I'm sorry, an ICD-9 or a SNOMED CT code that is stored there to indicate what that problem is. But the issue of where you actually put it and how you enter that in your EHR is a question more for your vendor. Somebody asked if they are podiatrists that they find that there aren't CQMs that pertain to their specialty. Can they report all zeros for your CQMs? And yes, you can. We do recognize that there are some specialties that are not specifically represented within that list of clinical quality measures. So reporting zeros is acceptable. Somebody asked about explaining the difference between CPOE and e-prescribing. CPOE is actually entering that medication order into the system so that it can bring up any type of interaction or clinical alerts because of that medication order, but it does not necessarily result in the prescribing of that medication. E-prescribing is actually the process of using the EHR to electronically transmit that prescription to a pharmacy so that the medication can be fulfilled. Somebody asked whether we were going to address here if there are any changes from 2011 to 2012. They already attested for 2011. And that's actually a really good question. If you attested for 2011, you are actually going to meet the same requirements in 2012, but you're just going to meet them for a longer period of time. So if you attested in 2011, you did your meaningful use of 90 days, and for 2012, what you'll do is meaningful use for the entire calendar year as an EP. Somebody asked, does a provider need to use EHR technology to attest? What is the penalty for premature attesting, or is there any? You don't necessarily use EHR technology itself to attest. The attestation process is you logging onto our website and entering that information. But much of that information is going to come from your use of certified EHR technology. So in fact, you can't attest ahead of time. You have to have gone through, acquired your EHR, used your EHR to meet those objectives, and then you come back with that information on the objectives you have met to do the actual attesting. So you don't attest ahead of time, you attest after getting your EHR and meaningfully using it. Somebody asked whether meaningful use applied to all patients or just Medicare and Medicaid patients. It actually applies to all patients. We discussed this a little bit in the rule, but essentially, although we had sought initially some comments about this when we did our first notice of proposed rulemaking in stage 1, the feedback that we got overwhelmingly was that trying to separate out Medicare and Medicaid patients from other patients and treat them in a different way would be excessively burdensome. So it is an application to all patients, not just Medicare or Medicaid patients. If a provider is only doing diagnostic tests, is he or she eligible for the EHR Incentive Program? So eligibility is determined by whether you meet a specific eligibility type, and you can take a look at our website to look at the different types, but essentially on the Medicare side, it is physicians, it is doctors of medicine, osteopathy, doctors of dental medicine or surgery, chiropractors, podiatric medicine. On the Medicaid side, it's physicians, nurse practitioners, certified nurse midwives, and then physician assistants under very limited circumstances. It's physician assistants that are in a federally qualified health center or a rural health center that is led by a PA. So that is your first sort of hurdle of eligibility, whether you fall into one of those eligible professional types. If you are, for example, a cardiologist who does primarily diagnostic tests. If you are an MD, you're obviously going to fall into one of those eligible professional types. The second hurdle is to check and see whether you are what we call hospital-based. If you perform 90% or more of your covered professional services, that's your Part B allowed charges under Medicare. If you perform 90% or more of those in either an inpatient or an emergency department of a hospital, then you would not be eligible for the program. You'd be considered hospital-based. But if you're a provider who is not hospital-based and you're one of those eligible professional types, then you would be considered eligible for the incentive program. And that's what the FAQ that we talked about earlier. If you don't actually see patients, you don't see them face-to-face, you don't see them in telemedicine encounters, that was how you establish a definition of seen by the EP during the EHR reporting period, so you would have a denominator on which to base those folks. And a lot of people who do diagnostic tests define the interpretation of those tests as being the actual seen by patients or seen by the EP. If a provider was with a practice and they filed under Medicaid the first year and now they're practicing on their own, can they switch to Medicare? And the answer is yes, that you can do that. You can log back into the CMS registration and attestation system, and you can go into the registration tab and you can actually switch your registration to the Medicare program. You can do that once during the course of the program. You can switch from Medicare to Medicaid or vice versa. And you can also, this person also asked if how they would change where the actual check was sent, where the actual incentive payment goes to. And that's also done during the registration process. You can go through and you can select a different NPI that the incentive payment would be paid to. scrolling through here. In a multi-physician practice, do all physicians have to use the same menu objectives and the same clinical quality measures? It's a great question, and the answer is no. Eligible professionals qualify for meaningful use individually, so therefore they can select different menu objectives and different clinical quality measures. In fact, in many multi-specialty practices, it probably doesn't make sense for everybody to look at the same clinical quality measures, because a gastroenterologist would not do the same things that a primary care physician would do. So you can certainly choose different objectives and things to report on based on the different EPs. Sorry, scrolling through here. How will public health items fit with EPs who are psychiatrists, psychiatric nurse practitioners, and clinics? There are exclusions in both of the public health objectives, and these objectives are reporting immunization data to an immunization registry or reporting syndromic surveillance data to a public health agency database. There are exclusions in both of those for providers who do not normally either collect syndromic surveillance data, or for providers who don't actually perform immunizations. They can be excluded from reporting on those public health objectives. Somebody asked if a provider has to see a minimum of 80% of their patients in the EHR. What if their providers work at separate hospitals or facilities? Do they have to have each of the facilities run reports for us on the amount of patients seen? So there's actually two different things that happen here. If you have a provider that works at a number of different practices, there is a minimum threshold that in order to receive an incentive payment, they have to see at least 50% of their patients in locations with certified EHR technology in order to be able to receive incentive payments. They can then base their meaningful use on just those locations with certified EHR technology. So if you only saw 50% of your patient encounters in places with EHR technology, then that 50% would become all of the patients that you would base meaningful use on. And then for those objectives where you have to have 80% of patient records maintained within certified EHR, it would essentially be 80% of that 50%. Sorry if that's a little confusing in too many percentages, but it essentially means that you can limit it. Once you meet the threshold of patient encounters with certified EHR technology, you can limit it to just those locations with certified EHR technology. When you go to a test, the EP is going to have information from all of the locations in which they see patients with certified EHR technology. So if they have 50% of their patient encounters in 2 different locations with certified EHR technology, they're going to have to get information from both of those certified EHRs at those 2 different locations, and they're going to have to add those numbers together in order to do a test. So somebody asked whether BMI would be included in the vital signs objective, and the answer is actually that BMI gets calculated automatically. It's height and weight that you enter, and then the BMI gets actually calculated from that. So you don't have to do the calculation. Similarly, you don't have to do the growth charts because that is automatically calculated as part of certified EHR technology. It's the height and weight that is used. It's height, weight, and blood pressure essentially is what you enter under vital signs, and the height and weight is used to calculate the BMI. Somebody asked if they could report the 3 core clinical quality measures and the 3 alternate core clinical quality measures instead of choosing 3 from the list of 38 additional clinical quality measures. And no, that isn't possible. You have to do 3 core You substitute the alternate core where applicable for core measures that don't apply, but you always have to select 3 from the list of the 38 additional clinical quality measures. Somebody said they've been told that a few of their EPs have been assigned to other groups, even though they work full-time with us and not the other entities. How do I get them reassigned to us? The assignment of the incentive payment is actually made by the eligible professional. It is not made by us. It is not made by another group. It is not made by a practice. The eligible professional is the person who receives an incentive payment, and the eligible professional can choose to reassign their incentive payment to another group or another practice. So if the EPs work for you full-time, you could approach them and ask them about reassigning that payment to you. Somebody asked whether Medicare Advantage EPs qualify for Medicare EHR incentives. They do. They are actually paid through the Medicare Advantage organization. And if you go to our website, the www.cms.gov/EHR Incentive Programs website, there is a Medicare Advantage tab on the left, and you can click on that and take a look at information on Medicare Advantage organizations. In a practice where Medicare and private insurance are accepted, must we report quality measures on private insurance as well, or just Medicare patients? The clinical quality measure reporting works in the same way that the meaningful use objectives work. It's based on all patients. It is not just based on Medicare or medication or Medicaid patients. Somebody asked if there was a list of the clinical quality measures on our website, and there is a list of those clinical quality measures. There, in fact, if you go to our website, on the left there's a clinical quality measures tab, and you can download a list of all of the clinical quality measures for both EPs and for eligible hospitals. Somebody asked, and this question has come up a couple of times in the last few days for me, for pathologists and radiologists who don't see patients in office visits, how do they meet core and menu objectives that don't have exclusions, but rely typically on the collection of information from an office visit? So, for example, maintaining an up-to-date problem list, or collecting demographic information, or maintaining allergy lists, so on and so forth. How do you get that information if you don't actually see patients face-to-face? So the way that pathologists, radiologists, and other specialists who don't necessarily have face-to-face encounters or telemedicine encounters would have to do that is by exchanging information with other providers. So, for example, getting that information either electronically or through paper and then entering it into your EHR from the provider who is transmitting that patient's information to you. Exchange is going to be the only way that you can get that information into your system in order to meet meaningful use. Somebody issued a clarifying question that they're implementing EHR technology, however, some areas aren't live, and a provider has already attested from an area that isn't live. Is there a consequence for this reporting before being live? Yeah, essentially you can't meet meaningful use with a certified EHR that hasn't been implemented yet. The entire point of the incentive program is you acquire the EHR, you implement the full EHR, okay, and then you actually meaningfully use that EHR, and then you come to us and you show us that you've meaningfully used it, and we give you an incentive payment. However, if you have maybe a practice with 3 offices, and your practitioner works in all 3 of those offices, but only 2 of those locations have the EHR up and functional, and the 3rd location does not have the EHR available. Then it comes down to practicing in multiple locations with an EHR, and it just means that that practitioner has to be able to show that they have at least 50% of their patient encounters in those 2 office locations where the certified EHR is live, and then they base it just on those locations where there is certified EHR. If an EP does not have a denominator for a core clinical quality measure, then the EP has to report on an additional measure from the alternate core. So an EP would report on 3 to 6 core and alternate core, and then 3 of the 38 others. But no matter what, they're going to have to report on at least all 3 of the core. So that is correct. Essentially, when you go into a test, you'll see all 3 clinical quality or all 3 core clinical quality measures. You'll go through and you'll enter data, and if you enter a 0 in one or all of those, then it's going to bring up that list of alternate core. You'll have to select replacements from that alternate core, and then you'll go to those 3 of the 38 that you will report on. So yes, it's going to be anywhere from 3 to 6 core or alternate core, and then 3 of the remaining 38. But you're always going to report on those 3 core, even if you report zeros. Let's see here. What if I accidentally submitted my attestation under the wrong date span? They were going to do one date range, but they forgot to change the date range. Can you change that after it's been submitted? Yes, you can. If you contact our EHR Information Center, you can go through and they will give you the process by which you can file an amendment to your attestation so that you can make sure you get the right dates in there. Very important in case you happen to get an audit request, you want to be able to show the right date range with the right information. Let's see, sorry, scrolling through for a few more questions. Somebody asked about meeting stage 2 requirements in October 2013 or beginning in 2014. I just want to reiterate that the final stage rule regulation has not been published yet. So what stage 2 will be, what the requirements are, what you'll need to do, and when all of that will take effect has not been finalized yet. We do expect at the end of this month, at the beginning of next month, for that rule to be published, and at that point in time, we'll be able to talk a little bit more about the stage 2 requirement. So for measures like vitals and smoking status, in order to be included in the numerator, must the data be recorded during the reporting period, or can it also be recorded anytime prior to the reporting period? That's a really good question. You know, for most of this data, we don't actually specify when it gets recorded. What we specify is that the patients who are seen during the reporting period have information recorded in the EHR. We're very specific that we leave it up to the provider's clinical discretion as to how often they feel that information needs to be updated, whether that is vital signs, smoking status, problem list, so on and so forth. It is about the provider's clinical discretion about updating that. We're just requiring that of the patients seen during that reporting period, that a certain percentage of them have information recorded. Somebody asked if 2012 is their first full year of EHR, when will they reattest? I'm assuming you mean that in 2012 it's your first year of doing your 90-day meaningful use, and then you would attest for a full year in 2013. However, if what you mean is that 2011 you did 90 days of meaningful use, and then 2012 you're doing an entire calendar year of meaningful use, and you're asking when you attest, you'll actually attest after the end of the calendar year. You will have 2 months after the end of the calendar year to attest, and you will be able to attest anytime in January 2013 or February 2013 in order to get your 2012 full year attestation entered into the system. Always encourage people to attest early on this. We have reached the end of our presentation. I'd like to thank everybody. There are a lot of questions here, and I'm sorry that we weren't able to get to everything. I hope this has been really helpful to everybody. Thank you again to all of you for attending. Thanks again to PAYCOM. Please do check out our website and PAYCOM's website for information about the EHR incentive programs.
This is my 11th conference in a row, and now I don't want to ever miss it again.
The PAYCOM conference is phenomenal. I would advise it for anyone.
I love this organization. What I tell people when they say, why PAYCOM, I say, these people are so committed to what they do, their professionalism in pursuing healthcare, their real, true interest in learning.
Deborah, good CMM.
I haven't missed the PAYCOM conference since 1999, and they are fabulous. Every time I come, they're marvelous speakers with great topics, timely subjects.
I have attended 10 conferences, and every conference I have brought back good material for my physicians.
The resources are amazing. The information that you receive is thorough.
I find these meetings very enjoyable. Again, you meet new people, and I don't think you ever come away from a meeting without learning one thing.
It's the camaraderie, it's the friendship, it's the connections, it's the networking.
I just think that everybody should come. It's value, value, value.